अनिता म्यूट ऑल पोड.
ते सांगतील ना किती द्यायचे आहे ते.
Recording started, ma'am.
Yeah. Anita ma'am, please go ahead.
Yeah, sure. Good evening, everyone. We are indeed happy and pleased to welcome each one of you for the ongoing mental health webinar series 2020-2024. And this is on behalf of the different organizers, the Department of Psychology, the American College of Madurai, in association with the Yellow Pond Counseling Center, Nolambur and Palikkadai, Chennai, and the Deccan Positive Mental Health Practitioners Association, Hyderabad. I would like to welcome our honorable resource person, the different coordinating team members for this wonderful session on diabetes, mental health matters, and we have our honorable resource person, Dr. Sri Priya Shaji ma'am, and very warm welcome to you, ma'am. Today we are into session number 1694th one, and she will be speaking. Happy to introduce her to all of you. She is from she's a nutritionist and a counseling psychologist from Srisha Counseling Center, Kozhikode. With that very short introduction, I would like to hand over the session to you, ma'am. The floor is yours. Over to you. Thank you so much once again.
Thank you so much, ma'am. Thank you for the introduction.
Most welcome, ma'am.
Good evening, everybody. Thank you for joining me in this wonderful initiative today. Diabetes, making diabetes an easy way is what the term diabetes is coined for. And we are going to discuss on the mental health matters. So before that, I'm just giving you a brief overview on what is Diabetes Day. It is on November 14th every year. And India has the second highest number of people with diabetes in the world. And it is expected to rise by over 134 million in the year 2045. So we are having estimated 77 million people above the age of 18 years are suffering with the type 2 diabetes. And more than 50% of diabetic people are unaware of their diabetic status, which leads to the more higher complications, and early detection and treatment is not properly taken. This is about the physiological things, but with the profound visionary words of Dr. M. Vishwanathan, who is also considered as father of diabetology in India, every person having diabetes should be helped to live his normal span of life in health. That is what he says. And as per WHO, health doesn't mean physical health. It is all about physical, spiritual, mental, and emotional well-being. So diabetes, like any other health condition, is also bringing in a lot of psychosocial challenges and also cognitive declines. So in this session today, we are going to see to that. Already ma'am has introduced me and most of you are aware about me. Still, I just want to say that I'm an independent researcher doing my studies in nutritional neuroscience and nutritional psychology. I'm running my own center at Srisha Counseling at Kozhikode, Kerala. So what are the things? What are the things I'm going to talk about? Am I audible?
Yes, ma'am.
Yes, you are audible.
So
Yes.
today we are going to talk about the connection between diabetes and mental health. What are the cognitive and emotional impacts, effective interventions, and coping strategies? And I'm also sharing what I'm doing in my center. So what is diabetes? First, let me introduce. The term was coined by me at the in 2021 for our initiative in Kerala, Community Nutrition Forum. We have thought of starting a right food education initiative. So it was started in the focus on addressing the psychosocial challenges faced by individuals living with diabetes. So later, it was not only used for Community Nutrition Forum, we also extended it for Mind Matters in 2024, covering wide coverage given for mental health aspects. And very importantly, Srisha Counseling is focusing more on integrated psychosocial support and psychological support in the diabetes care, aiming to ease the emotional stress and improve our overall well-being. So we all know there are different types of diabetes, type 1, type 2. Type 1 is mostly autoimmune, type 2 gestational, that is during pregnancy. And there are some single gene mutation and rare diabetes conditions like MODY and LADA, monogenic diabetes, and also latent autoimmune diabetes. So I'm not going to talk on the physical factors today. I'm just only focusing on the psychological factors in diabetes. The very first psychological factor in diabetes, like anybody, when we are told, not only diabetes, any disease condition, when we were told the health psychology is immediately people will get shocked. The second, whenever it is a non-communicable or any kind of diseases, apart from the communicable diseases, most commonly what we get is the shock. How can I get this? And we will deny. No, it is not possible. People run behind several centers to confirm. Like I have seen patients initially to confirm, they have run behind 10 laboratories to say that they are diabetic. Without that, they won't accept. They will have so many reasons to say, no, this is possible, that is possible. Yesterday, I went to marriage. To anything they will say, and they will get angry about themselves or the family members or their way of living. And next, they will fall into the guilt trap and anxiety will proceed. So, in the long term or short term, diabetes brings a lot of distress, which sometimes leading to phobic reactions also, especially in GDM and type 1 diabetes, and also in elderly. We are coming across the phobic reactions, that is mainly towards fear of injections or needles, hypoglycemia, and anything like obsessive behaviors. And yes, researchers are saying that psychiatric disorders is two-way. Diabetic people also getting more into depression and anxiety, and depressive and anxiety patients also getting more of early diabetic glycemic, uncontrolled glycemic. So what happens with the psychological factors? They end up in poor glycemic control, self-care behavior and adherence is poor, reduced quality of life, increased complications of diabetes. So what are the reduced quality of life? Whenever we talk about the quality of life, people think that the way of living. For example, if a young adult is getting diabetes, what happens is like this person is unable to go on duty for like timings is a problem. He is not able to reveal certain things to his career management. So he may hide his insulin injection or some things. Or sometimes he is also, even some companies also like they want to recruit only healthier staff. They don't want to take risk with the people with diabetes. So such psychosocial issues are coming. It is dropping their career. And sometimes even the parents, in cases of type 1 diabetes, parents say, don't go outside from our eyesight. Please better stay here along with us. So this is all stopping their career growth. And in middle age, there are so many middle age crises already. Maybe their children is growing, their parents is getting old, and they have to take care of themselves also all the time, monitoring. This is also leading to the poor quality of life. And continuous banging, like you have to remind certain things, and you cannot be free without any hindrance. There is a lot of hindrance with the proper management lifestyle. So people think it is hindering their proper way. Actually, that is not so. When there is a discipline, diabetes can be easily controlled. But that doesn't mean everybody is lacking discipline, but they are lacking their scheduling or they are missing their priorities. That is the problem. So their quality of life is reduced. So many people ask, is there any Excuse me, I request all the participants to keep your mic in mute. And so there is possibility of diabetes distress. How is it okay? Like how come people get into this? This is a very common questions we psychologists face today. What is the use of talking this? There is a very common burnout and diabetes distress because they have to be in control. It is a kind of, you have to be always monitored and be in control. So people are like into the way somehow I should do this. They're not thinking of the right way. And there are so many infodemics coming and so many targets are there, measures are there. They have to keep on having certain amount of patterns to be followed. When there is a pattern, automatically the brain starts getting stressed and burnout. Fatigue is very common. For example, if a woman or a man who has to work for 8 hours, he has to leave home by 7 o'clock and get back by 7 o'clock due to the busy traveling in Chennai like cities or Mumbai like cities. What happens in between their breakfast or dinner time is not scheduled properly. They could not fix it. Maybe it gets delayed because of their meetings, official meetings or anything. So these things also involved because they are not all the time sitting in home and only monitoring this. They have others many responsibilities, and the technology today is demanding more and more work from everyone. So the demands are high and the prioritization is very less to the health factor, especially in India. We very, like, our priority to health is the last one. And unless we get into certain disease, we don't prioritize our health in a very common way. That is also increasing the stress factors. So is there a distress? Yes, distress is very, very real and absolutely reversible. Diabetes can be always remitted, not reversible. Diabetes can be remitted, kept in control, and distress can be also reversible. So what is the burnout model? Like any other burnout, even in diabetes burnout, it is an exhaustion of so many things, detachment from the particular point and feeling of powerlessness. This is the very normal burnout model for any other psychiatric emotional issues. The same thing applies here. So the burden of diabetes self-care and lack of achievements in the control, because the control, like however I do somewhere something in my HbA1c slightly goes because it's a 3 months control, and co-occurrence of like life events or stages, like getting a job or getting pregnant, getting children, moving ahead, to the career options. Although co-occurrence events also like make it more distressful and lack of support system. Many a time, like the support system, what is this? It is a common problem everybody has. No, everybody has a toxic positive statement. Everyone has diabetes. Everyone has every problem. But you are not telling how to resolve it. How can it be okay? Like because everyone is having, I'm also having this problem, it's not okay. I should need a solution, or I should need a way of how to deal with it, how to cope with it. That is not said in any of our community. The community lacks very, very empathy is lacking very much in the community when it comes to such a non-communicable disease factors. What is the biggest challenges in diabetes distress is the emotional roller coaster. Anybody like very importantly, as I said earlier, denial, fear, desperation, panic, hope, depression. This is a very, very common thing in a normal diabetic. However, type 1 and GDM, it is very high. And this emotional roller coaster, almost every day they undergo this, especially in GDM, that is diabetes during pregnancy, the shock, worry, like fear is the very important problem for them, because they have to bring in the proper child. Everyone around them, they keep insisting on the regulatory kind of things, like this is what I followed in my system, or this is the cultural factor, you have to do this. There are so many things. And sometimes even we have heard people telling that doctors will say several things, you just follow what we say. This kind of unsupportive environmental fear about the children, and there are so many infodemics are there. Like people will say, oh, you got diabetes, your child is going to be cognitive impaired, or your child is going to be unhealthy. So sometimes you may lose your child. All these things together put pressure on the diabetic women. And this is leading to, within the 9 month span, they go into a very severe traumatic experience. And researchers are bringing out that post-trauma or postpartum mood disorders are very high in GDM women. So why diabetes and mental health are connected? Here are some of the statistics from research I have brought in for you as all. Like mental health disorders, especially depression, is approximately 27% of individuals experiences. This is a study from Johns Hopkins. And symptoms of anxiety are prevalent among people with diabetes type 2, especially in any diabetes, but type 2 also, it is very common. Not only in type 1 and GDM, it is very common in type 2, and elderly care, it is very, very high. And in a middle age, it is becoming a very important crisis. So one of the midlife crisis, it is becoming one of the midlife crisis is health impacts. Diabetes is becoming a higher state. Between 33 to 50% of our individuals with diabetes experience diabetes distress, characterized by the feeling of frustration, worry, and burnout related to diabetes management, is the research findings by Center of Preventive and Development. Yeah. So what are the diabetes status of depression? It is like as we said earlier, this is very high, and this status emphasis on the urgent need for medical health support with the diabetes care. So is it only just psychological functions or mental health functions? No. Recent studies are coming out and saying that cognitive decline and dementia. Even today, I saw a neuroscience magazine saying that dementia is very high with the long-term diabetes people. And when there is a impaired glucose control or a poor glycemic control, dementia is increasing. So increased risk of dementia like and Alzheimer's or dementia is very high, 50 to 100% higher risk of developing with those with diabetes, and older adults with type 2 diabetes experiencing the cognitive decline. We are seeing that even in our clinics or in our families and friends, like they start getting the poor cognition, lack of coordination, getting irritable, highly kind of forgetfulness, memory loss, and all those things. Cognitive decline is also very high when the people is crossing 5 years of diabetes. And mild cognitive, this is called accelerative cognitive decline, and mild cognitive impairment is also prevalent in 45% of people with diabetes. So long-term diabetes, especially above 5 years of having a diabetes, has been linked to cognitive decline, particularly in older age, especially above 60 years. And some of the 6-year studies involving 125 participants find showing that impacts of memory, attention, and executive function. So is this all about cognitive memory, dementia, or Alzheimer's? No, that doesn't end or stop there. We are also nowadays coming out with the very important problem, diabetes and eating disorders. It is very much prevalent and it prevails in India very high, especially in young individuals and also in the midlife individuals. So what is this diabetic eating disorder as called as diabulimia? And there is a dedicated website, diabulimiahelpline.org is also available. You can go and check more of this. So here we also experience same amount of anorexia, where people kind of, to avoid insulin, they do all the gimmicks, they cut off their carbohydrates or avoid the foods, restrict foods, and binge eating is very possible. Some days they become over, like I have to control my sugar, and they doesn't eat anything, and some days they so dejected and they eat everything. All this kind of eating disorders. And now very recently I'm having a very higher number of another case, orthorexia in diabetes patients. That is not a normal or not a formal eating disorder. It is a kind of obsession. They are like, I have to achieve this target, I have to be perfect in my diet. At least if my glucose is not controlled, I have to get the statement from my doctor, you are having a perfect dietary schedule. What they do is, without any knowledge of their individualized dietary pattern, they follow anything and everything in internet, and they start crushing their way of diet. And they sometimes, without like too much of obsession, they sometimes miss eating a proper nutritious foods. What are the impact of self-management and outcome of all these problems? It is again the poor glycemic outcome, and this is also leading again to, this is a vicious cycle. Poor glycemic control, distress, depression, again you eat improperly and you don't exercise, again everything follows. So this is a kind of vicious cycle. And John Hopkins public health studies say depression can lead to higher mortality rates, emphasizing the need to integrated approach. So what are the psychological interventions you have to follow in diabetes? So like any other disease, we have the first important model for mental health is biopsychosocial perspectives. So understanding the diabetes requires a biopsychosocial approaches, addressing the interconnected biological factors like physical health, disability, genetic predisposition. Like most commonly, all the obese patient has a very important complaint. They will say that everybody targets on my body. It's not about my obesity, my body or my eating way, or they call me a lazy bump when they come to know that I'm a diabetes. So there is so many other things behind their obesity. So there is things which we have to understand their biology also, the neurochemistry, what is their immune response, and all those things, and temperament of this beliefs, how they behave, how they eat, how they exercise, personality, what is their self-esteem level, what are their coping mechanisms used, or how are you going to address their social skills, peer relationship, family circumstances. Because another important thing is money. Sometimes most of our diabetes patients, they say, like, I have to go to work from morning to evening. I cannot afford this much of medication, or I cannot afford time for this exercise. I have to run behind. Even sometimes we can see the medical professionals, nurses, or somebody in IT sector, very, very educated people, I'm calling the professionals. These people will say, sorry, I am bound, not a time bounded work. My work can be extended from any time. So I couldn't accustom or adhere to certain exercise routine or certain dietary routines. So this kind of social support is also lurking. And very important thing is poverty. Poverty is also important to understand. So one best model for diabetes mental health or early diabetes distress management, we can call, even in the diabetes burnout stages, we can use this DSME as diabetic support and education, diabetes support management and education thing. This is a very detailed model. I'm not going to give you a detailed overview. This you can learn from DSMES in, you can see in the National Health Profile and all those things. Even any diabetic sites will have on this. So in this model, they are teaching, diabetes educator will be the first person to teach the client or the patient about how to deal with the diabetes, how to self-control the diabetes, how to eat proper diet, how to exercise, how to use the dosage properly, how to adjust the dosage, especially if they are in insulin, how to adjust, how to like have the plan for management. All those things will be educated and focusing on their psychosocial aspects. So this one model has to be briefly studied by any psychologist to understand the initial diabetes education part. So what is the very common question I often come across people like, oh, you are working in a diabetes sector or you are working for diabetes patients. What way diabetes means a psychologist have, what is the role for a psychologist in diabetes care setting? We can be a clinician, we can be an advisor for designing the several programs, we can be a program developers, we can communicate such problems like educating the patients or educating the nurses on particular individualist criteria. We can be the researcher or collaborator, and many roles awaits in the diabetes care pattern for psychologists. So how do I intervene or how do I address my patients? Like very first intervention I use is always that in the initial stages, every patient has a denial. So always I address their denial. I will talk to them, sit with them and use the gestalt therapy model to make them understand what is this disease, how, why it. People always have the question, why me? So this denial has to be addressed. Second thing, what we do is addressing their fear factors. Like many of our diabetes patients like get into the trap of poor management because in the initial stages, especially even recently, we had a very older lady, around she is 65 or 67. She is a very thin and fragile lady, but she's having the blood sugar of 518. So when people said like you have to immediately go for insulin management, the fear factor, oh, then I have to take insulin every day, lifelong, 3 times, 5 times. This kind of fear or myths are across. So we have to talk to them and find out what are the fear, and we have to give the right diabetic education and how it goes, how it works, what is diet, what is exercise, how much exercise at your age criteria or your type of diabetes. All these things has to be addressed, and educating on the rightful resources and care is a very important thing because in India for any health issues, what happens is they always approach the wrong people. When it comes to, I always ask my clients this one very important question. When it comes to your bridal makeup, where do you go? Whether to your beautician or to your cobbler? So the question stands there. Have a right and perfect person for having a diabetes care management. Second important thing is today there is lot many information. Earlier it was like even in 2000s when I joined work, it was kind of like I heard from my neighbor or friend or I read in some news magazine. But today it is not like that. Everybody in every minute they can go through the internet and download so many informations. Even what to say, social media influencer, well, just like that, a cook will post, oh, this is a very good juice for your diabetes, drink this every day. Or anybody, like even a dancer will say, oh, I control my diabetes with this. So any influencer can give any kind of statements which can cause a problem in diabetes management, because any care, any health care is always individualized. So We have to teach them never ever. And nowadays we are having another biggest problem. So many fad diets. People will say any Facebook or social media, you can see like, are you diabetic? Let's reverse. Or and I have recently found one very funny advertisement. We want 5 lazy women. We'll make you reduce weight. So such kind of foolish things which mostly affect people. Like they want some shortcut. Somehow I want to reduce this. Has to be addressed and we have to educate them, focusedly educate them on the right track for right health management and healthcare. And always unauthorized advices is going to put you in the trap. So that will not work. And educate on adherence. This is a very important area that psychologists peep in, because dietitian will be telling them about what kind of diet they should do. But adherence to the diet or adherence to the exercise is not always with just a proper education or advice. There are many difficulties. Cravings are there, lack of motivation are there, or lack of understanding is there. And there are many traps, like feeling deprived mentally. I'm feeling so stressed or overwhelmed, or I'm binge eating, or sometimes I'm ashamed of, like I have found one very funny kind of reels. Like the lady will say, like, always you're eating. So she says, yes, I'm, because I'm too much stressed. So the other one, what is your stress? Immediately she says, don't ask about it. After like pushing her, she says, I'm too obese. That's why I'm always stressed, and that's why I'm eating. So this kind of the vicious cycle goes on into the very big trap. But what is the neuroscience behind the poor dietary habits? Whenever there is a low blood sugar, like for a long time, people doesn't eat much, low sugar, then immediately they have cravings and they eat more. So the blood sugar spikes. Then immediately they feel guilty. Why did I do this? And again, this cycle of feeling awfulness and physically and mentally going into the vicious cycle of all this trap is very common. And when it comes to adherence to exercise, we have many reasons. Like there is a rain, there is a fall or winter or anything. We have any number of exercise procrastination. Mainly the impulsive or not able to exercise is also like directly connected to the impaired glucose tolerance. And this cycle also, like, it is a task. I'm feeling lone today. I cannot do this. So they have to come out of, break the cycle and come out of this procrastination cycle. They have to always use their better measures like a motivation or support group. Especially nowadays, we have finding a very good thing about the support groups in exercise, because one person is there to walk along me, is giving a lot of mental support. So people starts working, because earlier there are sometimes like I have to finish this work, I have to send my husband or children to school, or I have to go to duty on time, many things. So this procrastination cycle can be easily broken with the support group. If there is no support group available also, every individual should be psychologically counseled by the proper psychological intervention measures. You can use either CBT or DBT and break this procrastination cycle. So remember, life is not a race. Consistency is the very important key for diabetes management. So apart from this regular mental and distress, I have set a very important protocol in my clinic for the cognitive decline and frailty management in diabetes care, especially in the elderly. Above 40 years, we have started doing now. Earlier, we were like last 2 years, we were doing above 50 years. Now we've started doing this in above 40 years. So we have a comprehensive intake, like medical history, we will take cognitive screening using the MMSE questionnaire or Montreal Cognitive Assessment questionnaires, and physical frailty is also assessed, and also the diabetes control status is recorded. Apart from this, we also always record their baseline metrics like anthropometric weight, height, waist and hip ratio, HbA1c, and fasting glucose levels, lipid profile, and blood pressure. Any kind of their biological metrics will be taken care of. And though my clinic doesn't have all the setup, we constantly have a connection with this endocrinologist or neurologist or pediatrician. Like whoever the patient is taken care of will be involved within this particular pattern of the cognitive base structures.
Ma'am, you have muted it.
Sorry, ma'am, some sound is coming, like it's kind of,
Yeah.
I'm not able to find where it is coming from. Okay, let me continue. Integrated assessment and care plan. We have a integrated care plan in which we do the cognitive and psychological evaluation, like routine assessment and identifying the depression, anxiety. Sometimes we use DASH questionnaire. DASH 21 is the easiest questionnaire, or sometimes we also use the 11 scale. And sometimes we use the choreal questionnaires, cognitive assessment questionnaires. Then we use the nutritional evaluation. This is a very important thing, how much they use the neuroprotective foods or anti-inflammatory foods or vitamin-rich diet is also evaluated on the regular basis. And frailty index is also used, like we use the clinical frailty scale to assess the frailty levels and guide plans. And as and when we are in doubt, we always confirm this with the clinical evaluation by their physicians. We don't take risk by our own judgments. And we also do the physical activity assessment. We also have a set of make them to do certain things for like particular task, particular yoga and particular exercises is developed for strength, balance, and cardiovascular health. And also we are using art therapy to improve their mental health, especially in GDM or young adults. We are using art therapy. Even in the young adolescent girls and boys, we are using all this art therapy. So diabetes control is regularly checked as per the diabetologist advice, and medication review is also done by the diabetologist and their physicians. And every like bi-monthly pattern we have, and we involve every time, like when the patient comes, we involve them in some kind of 40 minutes of cognitive stimulation therapies. We have different type of brain stimulation activities, puzzle games, memory games, even this what you get picture sudoku, kind of different kind of activities will be given for the patients. And nutritional supplementations is given when there is requirement. That always goes with the doctor's prescription. And psychological support with the caregivers is another important factor, because when there is a dementia, like sometimes patients come and say, today also even one lady says that my daughter-in-law is not giving food. Then the daughter-in-law is very furious. She said, like, she's keep on forgetting that whether she had food or whether she had medication. Nowadays, I'm keeping medication away from her hands, because she will, like, once we have given medication, after another half an hour, she will come and say, you have not given me food or medication, give me my diabetes pills. So she should not take it on herself. So this frustrates the caregivers, because they are also enduring this for the longer period of time. No, this is not only the physiological, money matters. They just buy some medicine, give it to you. They have to be taken care of. So the caregivers is also frustrated. So we need to continuously educate them and give them the support. So we also have a monitoring follow-ups. Most of my patients, I insist them to do a food journaling. Every day they have to write their every meal in their diary, and they have to send every meal like once in a day during the night time. Late night, they can send it. So next morning, we'll assess and give them the assessment, how much portion control has to be and all those things. And we also do the bi-monthly follow-up to the patients. We call them, and sometimes we call them to the clinic and have the cognitive assessment and adjust the treatment plans accordingly. And now we recently came across something called home safety evaluation, which we are planning along with the physiotherapist. And apart from this, we are also conducting patient education workshops, caregivers training, support groups are in process. And we are also doing community education for diabetes control. And we also, because this is happening for last 3.5 years, we are doing this thing. So every 6 months, we review and update the protocol based on the new evidences we are finding and feedbacks from the patient, and also the other medical, like a neurologist or a geriatrician, whatever the feedbacks. Accordingly, we will be reviewing our protocol, and we have a very strong feedback mechanism. Thank you.
Thank you so much for a wonderful, incredible presentation, very comprehensive and useful session, ma'am. Thank you so much. Friends, if you have any questions, you may go ahead. Please raise your hand so that I can call out your names. There's a lot of positive feedback for your session, ma'am.
Thank you, ma'am.
Any of our participants here? Friends, if you have any questions, you may interact with ma'am.
Ma'am, request you to please share your PPT. It was awesome
Thank you, ma'am. I'll share the notes.
and very informative.
Yeah, ma'am.
Though
I'll
we don't
share the
suffer,
notes.
but it was really good because then you prepare yourself. If you could just mention what are the food that we should have and what we should not have.
Ma'am, in diabetes, I always insist, like you talk to your dietitian. There is nothing like you should not have and you should have. If you want to tell me in a very comprehensive manner, you should not have any of the junk foods, bakeries. Avoid all those things. Eat homemade healthy foods.
Yeah. Thank you, ma'am. Friends, any more questions? Do you have any questions? You may interact with ma'am. She's just waiting to answer them. Yeah, there's a lot of positive feedback from Komal ji here, ma'am.
Thank you, ma'am.
And Sarabim ma'am has also sent her feedback about the session. Thank you, everyone, for that wonderful feedback. And if there are no further questions, thank you, Benita ma'am. Thank you, Pinky ma'am. Thank you, Bharti ma'am. And if there are no further questions, with your kind permission, may I request Meenakshi ma'am to go ahead with the thanks. Shri Priya ma'am, can I request her?
Yes, ma'am, please.
Thank you
Thank you,
so
ma'am.
much. Over to Meenakshi ma'am. Yeah.
Thank you, Anita ma'am. It's a very wonderful and awareness session. I hope everyone enjoyed this. Regarding the how to maintain the diabetes record. Can you hear me, ma'am?
Yes, ma'am.
Thank you. It's a good section, ma'am. Thank you. Very wonderful session regarding how to record and how to maintain our mental health, as well as how to make to balance the any kind of a chemical reaction, and also how to control the food habit and regularize the exercise. Everything is wonderful. Hope everyone enjoyed. Thank you. Accept the gratitude from American College Madurai, Department of Psychology, American College Madurai, with the Elapon Counseling Center and Deccan Positive Mental Health Practitioners Association. Thank you very much, ma'am. Thank you. Ma'am, as far as recording is concerned, is with you.
Yes, ma'am.
Okay. I will inform Salim
I'll send it
sir.
to Salim sir, ma'am. Yes, ma'am.
I will inform because
Yes,
we don't, I don't have, because of internet failure, I haven't received that recording also. Okay, I inform Salim sir also. Thank you very much.
Okay, thank you so much. Yeah.
Thank you, ma'am, and thank you, everyone. See you all tomorrow. Thank you, ma'am.
Thank you.